Good afternoon, ladies and gentlemen. Once again, it's an honor to be here. I have no conflict of interest to declare. Outpatient colectomy is not a dream, as you have seen. It's not a myth, it is reality. And in our practice, it is done for the best interest of the patients and the society. And we will see without any opioid after discharge. But in this management, the patient plays a vital role. They are the central actor, of this management. But obviously, they are not alone. They have to know that it's all about teamwork. Each patient will be taken care by a group of professionals. And these care providers will communicate among each other at all times and will provide them the same information about, I have some trouble with this, about each step of the procedure. This patient needs to be reassured, and we will do this by explaining everything. The disease, for sure, which treatments are possible, and what kind of complications are associated with these treatments. And we have to be sure that the patient perfectly understands all their care pathway and are aware that complications may arise, but these complications have already been anticipated with an algorithm of solution. And if we succeed to explain all these points to the patient, we will give them a very good sense of security. To build our protocol, we have integrated all the ERASE recommendations. These items have to be known by all the members of the team, not only the surgeon, of the anesthesiologist, all of us. They are interconnected. For example, we know that preoperative clear fluids and carbohydrate intake 2 hours before surgery reduces postoperative nausea and vomiting, and consequently allows an early feeding, as does an optimal analgesia. A patient without pain will be able to move and to eat earlier than expected. And today, I want to focus on this point, on the pain relief. We all know that postoperative pain is a very complex phenomenon with multiple ways of activation, and we have to cut very shortly all this pathway. The best and the first treatment of postoperative pain is to reduce intraoperative pain. And that means for the surgeon to operate by a laparoscopic approach with minimal and gentle bowel traction. That means for the anesthesiologist to provide a very deep muscle relaxation which permits the lowest insufflation pressure. The analgesia must be initiated very quickly after the skin incision and must use different agents to act on the different pain pathways. We have to avoid opioids as much as possible, especially in colic surgery, and in our protocol, we don't use opioid after discharge. We have to convince patients that they are the central actors of their postoperative pain management. The oral painkillers intakes are crucial. It must be taken on a regular basis and not as needed. And in our protocol, we give a precise schedule of administration for each treatment. And we try also to give a positive conditioning about pain. We have to make patients aware that a low pain is acceptable, and it's not a fatality. It is something they will be able to go through. Our intraoperative protocol is summarized on this slide. The induction and maintenance of anesthesia are achieved by short-active intravenous drug, not volatile agents. We provide a very deep muscle relaxation until the end of surgery with rocuronium, with an antagonization with Zugamadex at the skin closure. We use anti-NMDA as ketamine as an anti-NMDA agent, and dexamethasone is used not only as an antiemetic drug, but also for an anti-inflammatory agent. On the opposite, we don't use non-steroidal anti-inflammatory drug, but it's our choice. We administer local anesthetics, which are a cornerstone of the pain treatment, by performing a bilateral tab block before the surgical incision. And right after the incision, we will give acetaminophen and nefopam. And at the end of surgery, at the skin closure, one single bolus of morphine. Let me give you some details about nefopam. Nefopam is a central inhibitor of the reuptake of dopamine, serotonin, and norepinephrine. It is a step 1 non-opioid analgesic with few side effects and widely used in France, but I don't know if it's available in the US. After the OR and the recovery room, we stop to use any IV route. All the painkillers are given orally. The analgesic protocol is based on an alternative intake of acetaminophen and nefopam every 3 hours with a precise schedule. It's not as needed. It must be on a regular basis. After discharge, the protocol remains the same, and the home follow-up is managed by a nurse or now by a digital device, and these pain score results are integrated in our algorithm of follow-up. Among our patients, the pain results exist so far in 153 patients. That means are fully available for these 3 first POD. You can see on this slide the median and the range for this day. Amongst our patients, less than 20% have had at any moment one pain score of above 4. We can compare this result to the literature because we have not found any study about pain after outpatient colectomy, but there are studies about postoperative pain for minor surgery performed on an ambulatory setting. As you can see in these studies, the percentage of patients with a pain score of above 4 is much more higher than in our series. So today we will conclude by saying that we have proved that it is possible to perform routinely and safely outpatient colectomy and to provide an effective analgesia without opioid. I hope that we have convinced you, and we would be very happy to welcome you in our hospital to let you see by yourself, but perhaps Le Havre is a little far from here. But I'd like to show you some parts of one of the educational movies we gave to the patient. It is the morning of surgery. This man is scheduled for an ambulatory colectomy. He's still at home. He still is in protective bacteriological environment, and he will come directly from home to the ambulatory ward just 1 hour before surgery, just the necessary time to be prepared for the surgery. Just after the recovery room, no rest for him. He will be asked to stand up, to sit, to have a drink, to eat, to take a shower, to walk, and to make exercise with the physiotherapist, as you can see. And our deal with our patient is, with all the patients, you will be allowed to go back home only if you are exactly this man. Thank you for your attention.
That's very impressive.